Delighted to have our dear friend Travis back. Travis, do you want to tell us what you've been up to and what news has, of course, hit us and hit the Twitter sphere and the larger medical med ed community?
Yeah, well, we're planning to do a medical school in Jacksonville, and we've partnered with a couple of the hospital systems here to support that. And I was just on talking with some students with it before, but honestly, we've had students in Jacksonville for like 6 years, and we have tons of preceptors who want to be a part of this, and really it's because of the students. They had a proof of concept that's been in play, because students will say, or preceptors will come and say, hey, I have students, I love your students, they're awesome. And they look at it as like a challenging, daunting task who's never taught medical students before, but they all know what it was like when they were in residency program and training. And then they get medical students who are great. And I see a couple friends that I just had in the ER, like Rebecca, who just matched in pediatrics. You get to work with them and they're like, hey, send me more students. I love this. And, it's creating a lot of excitement in Jacksonville to have a medical school in Jacksonville. They've been trying to do it for a long time. A lot of it is political why they haven't done it, but we're here to lead it, and looking forward to the next. It takes about 3 years to do for the accreditation process, but it's been a fun process to work through, and we're really excited about training and starting some new residency programs, and linking everyone to the clinical problem solvers. You're muted.
166 people. Welcome to all of you. We're thrilled to have you here today. I also see some familiar faces that I haven't seen for a while. I see Paul has joined us today. Ariel is back. I also see my dear friend and former medical student Sarah Zhu amongst the crowd, and many, many others. It's so nice to see you all. We're supposed to keep this to 30 minutes, so we'll jump right in, but we have to introduce the highlight. And the highlight is that I'm sharing the lukewarm discussing seat with the one and only Yasmin. Yasmin, you want to say hello?
Yeah, I will briefly say hello to everyone. It's really nice to see we have full house today. Wow. That definitely doesn't make me nervous at all. But it's really nice to see all of you today. And yeah, I can't wait to see what Dr. Travis has for us.
Oh my gosh, Yasmin. I also see Maria here, Adam is here, and the lion is here. Oh, wonderful. What a treat. We'll have so much fun. Well, Travis has not only graced us with such great news, but also has a case for us today. So, Travis, take it away, my friend.
I do, and this case we had in the ER a couple weeks ago, and I had Rebecca. We're going to make it a human DX case, and Rebecca, who's in the audience, helped kind of draft the case for us, and so we'll present it to you. It was a fun case, interesting case to take care of, and we'll start from the top. So I'll give you the HPI. Is a 42-year-old male presenting with 1 week of abdominal pain and vomiting. I'll leave it there unless you want a little bit more, and I can clump some of the other aliquots.
Yasmin, why don't you just share your reflex thoughts to this sentence? Literally one sentence.
Okay, for this symptoms, abdominal pain and vomiting, the first thing I will think is infection. But before jumping to a diagnose and just like case myself on one thing only, this patient can start. So I will first survey his how stable he is. I would definitely look at the examination, the physical examination, including pelvic. This is a male, testicular too. Examination. I will also look to the red flags. This is ER again. I'm like setting myself into this setting, redundancy apart. Risk factors: if he's immunocompromised, if he had surgery, if he has any history of any cardiovascular disease, coronary artery disease, if he has unstable vital signs. What are the pain characteristics? Abdominal pain is really a big, it has a myriad of causes, but I will ask if it was of sudden onset of severe pain, if this pain is sleep, if it is an out of proportion pain when I'm exploring this patient, if this person has an accompanying symptom, which is vomiting, I would like to know the nature of this vomiting, if it's bilious, if it's hematemesis, if also look for possible peritoneal findings or signs such as guarding, rigidity. I will look for rebound tenderness, and like listen to his bowel sounds, like the gross abdominal distension. What do you think about it?
I'm right there with you, my friend. I'm pretty worried about this patient because of the presence of both abdominal pain, which is often heralding of serious issues, and also the presence of vomiting. And I think a very good place to start is to think about the mnemonic VIPO, vascular, inflammation, perforation, and obstruction. Those are all the life-threatening causes of abdominal pain in a man. And you might add an E if there's a woman with a concern for ectopic pregnancy. And I just see that Shema already wrote this in the chat, way ahead of me as per usual. And so what nuance can you try to make progress? Vascular mesenteric ischemia, I, inflammation, P, perforation, O, obstruction. Of those, the only thing that really presents with focal pain is inflammation. Right upper quadrant equals cholecystitis, right lower quadrant equals appendicitis, so on and so forth. So I think the first key question is to try to figure out, is this diffuse or is this focal? And the truth is, if you're taking care of this patient in real life in the emergency room, you're asking yourself a little bit more of a practical question, which is, how do I actually find out what's going on? And nothing that we can do on our history and exam is as powerful as imaging, usually a CT scan. So it's really helpful to know, how can I diagnose this patient usually, and it's through a CT scan. Can I do anything short of a CT scan to diagnose this patient? And the answer is yes. It's usually two things or three things: DKA, pancreatitis, and urinary retention. So very quickly, you want to get a point of care glucose, a lipase, and bladder scan. And if those are not revealing, your patient needs a CT scan. In real life, it's very simple. You don't have to think this hard. You just sit there, you're like, vascular inflammation, perforation, obstruction, all those are CT-based diagnoses. And my only way out of a CT scan is usually through pancreatitis, DKA, and urinary retention. So as you try to simplify these things, I think the evaluation in these patients tends to be more simple than the range of diagnostic possibilities. All right, Travis, tell us more, please.
Excellent. So on further questioning, he reports he has not been wearing his continuous glucose monitor, his Libre 3, over the last week. He usually uses short and long-acting insulin, but reports poorly managed glucose control. And he'll often wake up with readings in the 300s. And he hasn't been taking his insulin because he hasn't been eating, because he's been vomiting, and it's just been a cycle. He's got a past medical history of type 1 diabetes for the last 15 years, history of atrial fibrillation. He had an ablation 3 months ago. His medications include apixaban, Lantus, Novolog, metoprolol, and flecainide. His first set of vital signs: his blood pressure is 160/103. His heart rate is 202. His respiratory rate is 24. His O2 sat is 96%, and he's afebrile at 36.4 Celsius. On exam, he's alert. He's in moderate distress and discomfort, actively vomiting. He's diaphoretic. He appears ill. His oral mucous membranes are dry. He's got a subconjunctival hemorrhage in his right eye. His heart rate, he's tachycardic and irregular, no murmurs, rubs, gallops. His abdomen is soft, non-distended, and he's got mild diffuse tenderness to deep palpation without guarding or rebound. No palpable organomegaly. His neurological exam is unremarkable, no focal deficits. And his EKG that was done, usually EKGs are always done in triage, shows atrial fibrillation with rapid ventricular response. I want to say it was like 160 without any ischemic changes noted. And that is the end of this aliquot.
As mean, your patient's heart rate is 202, but thankfully it's now lower to 160. Let me just ask you something a little bit more specific, because there's a lot of information here. What do you think about the abdominal exam?
I think it's really not like, it's not like, it says that it's mild diffuse tenderness, and we don't have any palpable organomegaly. So right there, I wouldn't are completely any causes in the like liver or spleen. But the first thing that came to my mind when I saw that this patient has AFib past history, and this heart rate, this blood pressure, this heart rate specifically, is acute mesenteric artery embolism, because I remember more than 50 or 60% cases, the most common cause of it, the risk factors are atrial fibrillation, as well as issues such as myocardial infarction, or valvular heart disease. And that's my first thought, something vascular going on here, acute mesenteric artery embolism. And this is obviously just basing myself on clinical, and because of this heart rate. So what do you think?
I couldn't agree more. I'm curious, how does his history of diabetes and sugar monitoring, what does that make you think of?
First of all, this patient is already on our red flag of immunosuppression. I also see diabetic ketoacidosis, if I'm not wrong, can present with abdominal pain. So obviously the labs will tell us more, but still, he's not taking his insulin because of his gastrointestinal symptoms. Still, I would try to see my patient is correctly hydrated, but I would first see like the labs.
100%, absolutely right. I think you're naming the two most important diagnoses here, which is, could this patient have diabetic ketoacidosis or DKA? Could this patient have acute mesenteric ischemia? I think those are absolutely superb. Again, if you just try to simplify this, there are a million causes of abdominal pain. The diagnoses that you can capture before a CT scan are pancreatitis, DKA, and urinary retention. And all of a sudden now we have to highlight DKA because of the patient having diffuse abdominal pain and who has hyperglycemia. So that is very much a possibility. The question is, why would this patient suddenly develop DKA? And the most common reason is medication inadherence, starts with an I. Unfortunately, that is, though it is common, it is a diagnosis of exclusion. And reasons that the patient might go into DKA are some other things that start with I. Infection, inflammation like pancreatitis, and most importantly, ischemia. Acute mesenteric ischemia is a notorious trigger for diabetic ketoacidosis. So I think that this case is set up for you and us to make a mistake, because we see that the patient has a glucose of 300, and we might see that the patient has ketosis or DKA. And you might stop there, but I don't think you should, because you still have to answer the question, why does this patient have DKA? And one important possibility is mesenteric ischemia. So even if this patient does turn out to have DKA, you cannot have that be your terminal diagnosis. You have to ask, why is this patient in DKA? And in a patient with atrial fibrillation, you have to wonder, could this person, as you said, have acute mesenteric ischemia? Absolutely superb thinking. Practically speaking, you probably want to get your ketones from the urine and from the serum ordered right away, and then get the labs and probably get the CT scan. All right, Travis, let us know.
All right, so I'm going to give you some labs and some imaging, and then I'll save one more aliquot for the final. So his CBC shows a white count of 10.2, a hemoglobin of 14.6, a platelet count of 445. There are no bands. It is slightly neutrophil predominant, 78% neutrophils, 15% lymphocytes. His chemistry panel shows a sodium of 132. The potassium was 6.5, but it was hemolyzed. And I think the repeat was like 4.8. Chloride was 92. Bicarb was 18. Glucose was 629. BUN was 23. Creatinine was 2.4, which is a little bit elevated. He has CKD 3, and I want to say his last creatinine was in the high ones. He had an anion gap of 22. Bilirubin was 0.7. Calcium was 9.2. Alk Phos was normal at 118. His AST was 30. His ALT was 30. His PT, INR, and PTT were both normal. Urinalysis showed 1 white cell, 2 red cells, 40 ketones, nitrate negative. COVID test was negative. Flu A and flu B were negative. Chest X-ray was normal. No infiltrates, no effusions. And the CT abdomen pelvis was normal. And I'll give you one more set of labs, and then the last will be what I think is the ultimate diagnosis. So beta hydroxybutyrate was 3.9, was mildly elevated. Lipase was 22. Serum osm was 316. And a venous blood gas showed a pH of 744, a PCO2 of 45, and the bicarb on that was 31, and the O2 saturation on it was 77. And that was a VBG, not an ABG. So that is it for that aliquot.
All right, Yasmin, what do you think?
First of all, that hyponatremia is common in diabetic ketoacidosis, if I'm not wrong. It can be due to hyponatremia or hypertonic hyponatremia. And also that potassium, even if it's 6.5 hemolyzed, I remember it's 4.8. It's just that elevated level on ketoacidosis. And I'm thinking with cause either hypertonic, I don't remember the name in English, but it's hyperosmolar hyperglycemic state, if I'm not wrong. And I would definitely take a look at this ECG, because I remember that when we are trying to lower that potassium, we have to look at the heart to see if we need to stabilize it with calcium gluconate, and think about first correcting electrolytes. That's something I would do first. And also intravenous fluids with insulin and glucose. The CT, looking at it normal, I still don't think we should just discard a mesenteric ischemia, but I so far thinking, what do you think?
I love what you ended with. I think, one, you taught us how to manage this patient, but also how the fact that the CT is negative does not eliminate some scary diagnoses, including mesenteric ischemia. Although the people with mesenteric ischemia, their CT isn't, if it's missed, the vascular occlusion is missed, they often have some signs of colitis, but the vascular portion may be missed. So the question is, does this patient have one of the complications of diabetes, either DKA or HHS? And the answer is maybe not. For HHS, you need to have some alteration in mental status, which he does not have. And for DKA, you need to have the A part, the acidosis. While he has the hyperglycemia and the ketosis, his VBG does not show an acidosis. And so you have to step back and say, well, hold on. If this was a mild case, you might say this is mild DKA before the acidosis kicks in, but this patient has a heart rate of 202 and has severe abdominal pain and vomiting. So DKA is not a sufficient explanation for the degree of abdominal pain he has and the degree of AFib with RVR that he has. So then it becomes a question of what is the overlap between the two Venn diagrams that I think we have, which is triggers for DKA or hyperglycemia and CT negative abdominal pain and AFib with RVR. Try to picture those three problems. What triggers hyperglycemia? What causes AFib with RVR? And what causes serious CT negative abdominal pain? And as a good general rule of thumb, the causes of CT negative abdominal pain are some very common ones, including mesenteric ischemia, as you said, Yasmin, and including hepatobiliary disease. Sometimes stones obstructing the gallbladder or obstructing the common bile duct may not show on CT. The most important category outside the common ones are endocrinopathies. And there are two of them, adrenal insufficiency and hyperthyroidism. Both of them can cause pretty significant CT negative abdominal pain. Adrenal insufficiency is probably more common as an association with, as a probably more common cause of CT negative abdominal pain. However, it's less associated with hyperglycemia and with tachycardia. In fact, most patients with adrenal insufficiency usually have low blood pressure and no tachycardia. They lack a compensatory tachycardia. It's an interesting feature. So the question is, Yasmin, what do you think is a more powerful trigger of AFib with RVR? Adrenal insufficiency or hyperthyroidism? What do you think?
I would think hyperthyroidism because it's more prevalent, but I wouldn't discard any of those before, because we have like the hyponatremia, which makes adrenal insufficiency, also hyperkalemia, but also this patient has really high heart rate that cannot let me get rid of my differential diagnosis of hyperthyroidism.
I completely agree. I'll share with you one of these Venn diagrams. So my mind is here. Triggers of hyperglycemia. Infection, we found nothing. Ischemia, CT is negative. Pancreatitis, not happening. He doesn't have a FeO. The CT is negative for it. He didn't take anything. It's not his initial presentation, and he's taking his insulin. So I think what I would do in real life is I would send an AM cortisol and I would send a TSH and T3. Those would be my most worrisome hypotheses. If those were negative, I think we can take a closer look at the CT negative abdominal pain schema, but I'd be pretty curious what this patient's TSH and T3 are, and then their AM cortisol. Any final thoughts before we learn from Travis, Yasmin?
Maybe thinking about if this is something happening from his thyroid, maybe look for signs of storm. Although it's like a very high jump, I believe. I can't wait to see what else Dr. Travis has for us.
Me too. All right, Travis, let us know.
All right. So basically the course of care, I gave him tons of IV fluids. I started him on diltiazem drip and gave him a bolus, which actually didn't touch his rate. I mean, his rate might have been down into the 140s, which was fine. It wasn't 200. 140s is okay. And I felt like, his rate in the 140s was probably compensatory, not eating, not drinking, vomiting. He's not been able to hold down his apixaban nor his flecainide, and maybe that's why he was in AFib with RVR. So he went to the ICU, and the ICU added on a few things, which included a TSH, which included a free thyroxine, which included a TSI and a thyroid peroxidase antibody. So the TSH was less than 0.01. The free thyroxine was elevated at 2.6. The T3 total was 212. The TSI was elevated at 2, and the TPO antibody was elevated at 59.7. So that is, I think that was the trigger for it. Again, I didn't diagnose it. The ICU team did. I tried to stabilize him, but it was, I think a good teamwork. And, with our team, we kind of looked at, was this thyroid storm? Was it thyroid toxicosis? And, maybe a beta blocker would probably be a better medication to put them on for a drip, but we always jump to diltiazem. So want to hear your thoughts on it.
Travis, I think this is an absolutely amazing case. You told us to be careful about connecting a syndrome in a patient with diabetes to diabetes itself directly, but you might just have to insert the other autoimmune complications of type 1 diabetes. So I think this is a great reminder of how important it is to know the difference between type 1 and type 2. And patients with type 1 diabetes are at higher risk of developing other autoimmune endocrinopathies, including hyperthyroidism and adrenal insufficiency. So you have to be open to that possibility. I'm so glad you didn't use amiodarone to rate control this patient. It probably would have caused much worsening of his atrial fibrillation, because the iodine in there can cause badness. And yeah, it's really hard to diagnose these cases in the ER when you're actually dealing with a heart rate of 202, but stabilizing him allows people to be able to pause and think more rather than be worried about acute management. Yasmin, how did it feel for you?
I really enjoyed this case, how you brought or the source, and then the patient does with tachycardia. He had the past medical history of atrial fibrillation, but we have to assess these patients. And if I'm not wrong, the etiology, that stress-related catecholamine surge, can be due to diabetic ketoacidosis. So just to find out what came first, if the patient had immune issues that not only affect the pancreas but also the thyroid, he's under treatment, or I don't like say not compliant with his treatment, but sometimes the adherence issue to the insulin, diabetic ketoacidosis, and then that's why he had thyroid storm. So it would be interesting to know what came first.
I couldn't agree more. I love that. It'll probably be impossible to know how this initial cascade happened, but I think it really pushes you to start to think hard about it. Travis, thank you again for such an amazing case, and we're excited for David to take us through the journey of the tuning points again. Take it away, David.
So great case. I think it's always difficult to diagnose such cases. We started with abdominal pain. Some of the red flags for this symptom are the sudden onset, the recent surgery, the fever, if the patient is unstable or has peritoneal irritation, or if she's pregnant. And Rabih stated the mnemonic DIPO, vascular inflammation, perforation, obstruction for this acute abdominal pain causes. We later talk about how can we diagnose some causes of abdominal pain without the CT, and there are mainly three causes that we can confidently say that these are the causes of abdominal pain. There are DKA, pancreatitis, and urinary retention. There are other image negative abdominal pain causes such as hypercalcemia, adrenal insufficiency, porphyria, some meds and toxics, some functional and other causes, but it's hard to tell that they are the cause of the symptom without previous CT. We later we know the history of AFib and diabetes. We talk about some DKA triggers such as infection, inflammation, ischemia, ingestions, or inadherence. Rabih in the chat talk about this syndrome that can appear with abdominal pain after ablation. That it seems to be something similar like gastric outlet obstruction from damage to the vagal nerve. And we later talk about what triggers of this case that appear with hyperglycemia, AFib, RBR, and CT negative abdominal pain. And in this case, that the patient had a type 1 diabetes and is at risk of other endocrinopathies. Adrenal insufficiency and hyperthyroidism could be at play. And I liked also the peril that Rabih stated about adrenal insufficiency causing hypertension, but a lack of compensatory tachycardia. And when we later get to know the final diagnosis of thyrotoxicosis, that I think is always difficult to make it like that diagnosis, especially in the ER. So very grateful and
Amazing job, my friend. Amazing. It's so cool to see you summarizing such complex teaching and Yasmin to discuss this case in front of over 100 people. It's got to be a little intimidating, but honestly, we're really, really grateful to you both, and great to have our beloved Travis back sporting his DX white coat. I love it. Love it. Yeah. All right. Really great to see you. Hope you have a wonderful Thursday, and I hope to see you around next time.
Bye, everybody.
Bye.
Yeah, that's right on.